Welcome to Radiologists, a podcast by University Medical Imaging Toronto, where we discuss the most important topics through the lens of Canada's largest medical imaging department. Today, before I introduce my guest to you, I want you to imagine something, picture something that we have seen 1,000 times in the movies. We have this legendary sheriff of the West, the legendary gunslinger, who's riding off into the sunset. There's this amazing orchestral music playing, the Western music playing, which is beautiful. And it's a long shot and he's just riding away. And in one final moment, he just pauses. He turns back. There's a sigh, but a big smile on his face. What is he thinking? He's looking back at the path that he came through. Where is he going? Is this goodbye? Is he going to hang up his boots? Or is this the beginning of another amazing adventure? To answer these questions, we have somebody in the exact same scenario, Dr. David Mikulis. Dr. Mikulis, for those of you who are not aware, is a full professor and director of the JDMI Functional Neuroimaging Lab at UHN and University of Toronto. He is fondly regarded as the father of functional MRI of Canada. And I present to you Dr. Mikulis.
Thank you for inviting me to present here this morning.
We are so interested to hear all your stories. In fact, just last night, we had an amazing retirement party for Dr. Mikulis, and he had so many wonderful stories to tell. But how did it all start? Because according to the latest statistics in the US, radiology continues to be one of the most sought out specialties. There was this brief period in time in which there was apprehension because AI might take our jobs, but that has been soundly put to rest, and it's still one of the most hotly taken specialties in the current day and age. But I imagine that when you started out as a radiologist, that probably wasn't the case. There was no CT at that time. It was just too early in everybody's career. Radiology was not really well established. So how did you end up being a radiologist?
Well, that's a great question. And as I look back at my early career in decision-making along those lines, it was not necessarily a straightforward decision. And I don't think it is for anyone. But it all began when, first of all, I guess I have to say, I'm American. How did I end up in Canada? And it begins with the story of when I was an undergraduate. My undergraduate training was in physics. And at that time, we were all assigned an advisor. And I consider him a great mentor, but I didn't really understand the implications of the mentorship he provided at that time. When I walked into his office, I saw this device on one of the desks in his table. And I said, well, what is that? He said, that is a prototype of a CT scanner. And this was in 1972. Now, this mentor of mine, his name was Alan Cormack. And he was a particle physicist, and he had done the initial mathematical advances to be able to reconstruct images from an X-ray that's rotated around objects, which is how CT works. He did that work in the 1950s. And what's really amazing is if we had had the computer technology to do the data-intensive calculations, we could have had CT scanning in the 50s. And if you look at when it finally got developed, which was in the mid-70s, that's 20 years where CT imaging could have actually saved lives. But it wasn't developed because the computer technology hadn't existed. So what happened at that point was I was impressed by that, but it didn't register to me that this was going to influence my career. In fact, one of the other staff physicists had asked me to become a master's degree student in his program. And I thought, physics was great. It would be a really fascinating career. But you're influenced by your peers as well. So all my peers at that time were going to medical school. So I said, physics, medical school, what should I do? And then the decision was clear. I'll apply to medical school and see what happens. So, of course, I applied to medical school, was accepted into medical school. And then that's where the next phase of my career began. And when I was in medical school, I was very sort of adept at looking at histology and pathology slides under a microscope. And some of my students would say, can you help me with this slide and tell me what this is showing? Because we were given unknowns. And I would say things like, well, you know, there are eosinophilic cells over there. I'm worried about those cells. That's going to be probably bad for the patient. I would make comments like that. And some of the times, more frequently, I guess I was right when I was doing it. So that was a talent that I felt I had a little bit of an advantage for over my average friends in medical school. So then the next thing that had to happen was, at the end of medical school, you have to make a decision about what kind of practice you want to go into. And I was struggling with that. And then, like I said in my retirement dinner speech last night, it was a spring morning. It was a beautiful, warm day for the first time. The blue sky was out. There were clouds in the air. And I looked up, and I don't know where it came from, but the idea said, radiology. That's where you're going to go.
Well, that's a very interesting story that you say that your radiology career began because it was a bright spring morning and it was blue sky, clouds, and everything green. And then you decided that, you know what? I don't like all of this. I'm just going to shut myself in a dark room, not see any of this again, and end up being a radiologist. Yeah, I'm just joking. But it's great that you managed to identify something which you were good at, which was being able to detect stuff, being able to identify stuff, characterize stuff in a very large population. Like pathology, it's pretty much the same skill, but then apply it into an emerging field to make that field or grow along with that field and push the boundaries of that field. But I think it was still early in radiology. And how did you end up being a neuroimager? Because I think at that point of time, radiologists were just considered radiologists and there wasn't any subspecialty as they exist now.
That began when I entered into a residency in radiology, and I was faced with similar decisions. You can't do all of radiology, although I do respect very much the efforts that general radiologists make because they do have to be a jack of all trades. But I had a background in physics and I was interested in technology. And at the time I was doing my residency, there was a technology called NMR, nuclear magnetic resonance, that was able to produce images of the human body that had multiple parameters that you could change and change what you're actually seeing on the screen by changing those parameters. Whereas a CT scan has only one parameter you can change. So I was really excited. I said, we can see things in the tissues that CT scanning cannot see. Oh, and by the way, I forgot to mention, my mentor, when I was an undergraduate, won the Nobel Prize in Physics for his discovery of CT scanning. He's not as well known because Hounsfield was an engineer who took his concepts and put it into, developed a machine that the first human being could go into. So that goes back to the idea that there's evolution of imaging technologies. There's a constant evolution and improvement in imaging technologies. So at this point, this NMR was this new fancy imaging technology that could see things in the human body that you could not see with any other imaging technology. So I got very excited about that, and I decided I was going to rest my entire career on that technology. And NMR is now called magnetic resonance imaging, and they made the name change because they wanted to take nuclear out because people would be afraid to have a nuclear scan. So that's how MR evolved, and then I had run into my second great mentor at that point in time. And he said, you're making a wrong decision. I said, how could I be making a wrong decision? I have a physics background. I can understand the MRI technology, and I want to apply it. He said, never apply your efforts solely in one imaging technology. What you should do instead is apply your efforts to learn the diseases of a body system and then become fluent in applying all of the imaging technologies to study it. and I took his advice. His name was Dan O'Leary. He was an NIH-funded neurologist turned neuroradiologist who was studying the blood flow to the brain, which was another impact on me that subsequently influenced my future because he studied blood vessels supplying blood to the brain. And the disease he studied was atherosclerosis, and he was using ultrasound to do that. So that's the decision that led me to thinking, okay, I am going to go into neuroradiology, and I need to apply for a neuroradiology fellowship. And when I applied for that fellowship, I was very fortunate to get into one of the best U.S. hospitals, which was the Massachusetts General Hospital. And they had terrific mentors there. So I have now another series of mentors that influenced my career tremendously. So when I arrived at Massachusetts General Hospital, my first encounter with our division chief was not the best encounter. He had known that I was moonlighting as a resident, and that was not an uncommon experience for residents in the United States to be doing. It's uncommon in Canada. But I was moonlighting. And the first thing he said to me when he met me was, if I catch you moonlighting, you're out of the program. So, okay, I said, fine, I'll not moonlight. And then I found out a lot of my fellows were moonlighting. And so I did a little bit of that, not as extensive as some of my other colleagues. One day, I was asked to see the chair of radiology at the Massachusetts General Hospital, and I was told by the secretary of the division chief to go now. Like, stop what you're doing, go there right now. And I started shaking, thinking that they found out I was moonlighting. So I walked into the office of the division of the chair of radiology, and his secretary was there, and she said, you have to sign these papers. And I'm going, oh my God, this must be termination papers. So I said, what are these papers for? And she said, didn't they tell you? I said, no, they just said, come in to see you and sign these papers. She said, you're now junior staff. I'm no longer a fellow. They hired me. So literally within a period of 5 minutes, I went from, this is the end of my career to, wow, my career has just taken a major advance. It's the job, exactly the job I wanted. And then from that point on, I met my next great mentor, who was Juan Taveras. Juan Taveras is the father of neuroradiology. In 1962, he invited 14 neuroradiologists to a dinner meeting in New York City, and they formed the American Society of Neuroradiology, which I still belong to. And actually, I'm going to a meeting due to some presenting in about a month. And so what he told me as a mentor was that you shouldn't just study MRI, you should study a disease and become an expert in this one disease, the imaging of one disease. And he told this to other fellows as well, but I didn't follow his advice. I wanted to study every disease that affected the brain. And even though I wrote the chapter of his textbook, the first chapter, I believe, in MRI imaging of multiple sclerosis, I wanted to do more than that. So as a result, I encountered a team of scientists at Mass General Hospital that were working at something that interested me tremendously, which was functional neuroimaging. And these were people, Bruce Rosen, Ken Kwong, Jack Beliveau. They had figured out a way to look at brain networks, where they're located. So, for example, if I were to tap my fingers, they were able to image exactly what brain circuit is being turned on when you tap your fingers. And they were the first to do this with MRI. It had been done with PET scanning, but it had not been done with MRI. So I've actually volunteered for some of the work that they were doing. I spent 3 hours in an MRI system from midnight till 3 a.m. because that's when we had research time, being a volunteer for this. So I got very much involved. I was very excited about it. And suddenly my career just opened up. You know, it's like the sunny day with the clouds and the blue sky. It happened again, and everything was falling into place for me.
That's an incredible story. Because what led you into medicine or taking radiology is the inspiration you got from watching or looking at that prototype CT scanner in Dr. Alan Cormack's office, who eventually, as you pointed out, was a Nobel laureate. And your thought process that this technology, if available 20 years earlier, could have saved lives. The second point was NMR or MRI as it stands now. That is what shaped your career in neuroimaging. As in, okay, now it's my turn to kind of use this next technology to save lives. But it's impressive that you just didn't stop there. You always wanted to be ahead of the curve. You wanted to push the boundaries. You wanted to make sure that a technology which is available now could save lives at the earliest, and that transitioned into your passion to advance functional MRI to make meaningful changes. And that kind of translational research takes a long time, takes a long effort, but once implemented can influence the outcome of a huge generation of people. So can you talk a little bit more about your research and how you managed to push the boundaries of MRI and how that can be brought into practice?
You're absolutely right. So getting back to what I said previously, Juan Tavares had a very important impact on my life because he encouraged us to submit abstracts to national meetings and to present our early work, and then to convert those abstracts into peer-reviewed papers and contributions to the literature. So that got me very interested in academics. I was convinced that I wanted to be an academic radiologist. I didn't want to go into private practice. And I was bitten by the idea that we could translate advanced imaging techniques into the clinic. We had new tools to do so. And that was the fundamental mantra, you could say, for my entire career thereafter. I wanted to do translational medicine. I didn't want to just take the imaging technology as it was and do standard imaging. I wanted to take it to the next level in any way that I could. And I can't say that, I didn't think I was going to win a Nobel Prize. That was never in my mind. I just wanted to make the incremental changes that would change the standard of practice of radiology to make it just a little bit better for people to who had disease to be assessed in a more advanced, more accurate way, more informative way that would then let the clinicians make informed and better decisions about their patient care. That was my whole modus operandi for the rest of my career.
Radiology as a whole at various points had such an impression on your life, and it changed your life completely. What would you think is your biggest accomplishment overall?
Well, I think the listeners may be surprised to hear this, but it was actually meeting my wife. So let me tell you the story about how this happened and why I've made this such an important piece for my career and moving forward. So in the old days, we had film. We didn't have monitors to review images, so we had film, and they were in film bags. And one day, this gorgeous neurologist walked into our reading room, and she kind of trundled over to me with a bunch of films from MRI and CTs and asked me if I would go over these cases with her to help her understand the diseases that were affecting her patients. So we went over a number of studies, including MRI, and when she left, a lot of people in the room said, "Wow, who was that?" So I noticed this myself, and then I wasn't thinking too much of it at the time. But then she came back the following week with another pile of films to review, and instead of trundling over, she kind of beetled over to me, and I said, "That's interesting." And so we went over the films, and then one of my colleagues, another neuroradiology fellow, said, "I think I've got some inside information for you. I think Gabrielle may have a bit of interest in you." And so, of course, what I did with that information was, in those days, we had pagers, and I would frequently page residents and fellows with the results of imaging studies. So I paged her, and she didn't think it was anything unusual. But when I paged her, I said, I'm not trying to convey any information about imaging studies. I want to see if you'd like to go out for dinner. Of course, she said yes. And that was, from then on, love at first sight. We got married. And what was interesting, she was Canadian. So she was at Mass General Hospital doing her residency and fellowship in neurology. But she was on a J1 visa. And the J1 visa, I don't know if people are aware of, but if you come into the United States on a J1 visa, you can train and stay there while you're training, but you cannot, if you're a physician, go into practice. You have to go back to your country of origin for 2 years before you can come back. So we got married while we were still in Boston, and we decided, well, we'll go come to Canada for 2 years, and then we'll find jobs in the United States. Well, that was the plan, but what was amazing was the positions that both of us acquired early in our career in Canada. So I was at the Toronto Western Hospital, and when I got to the Toronto Western Hospital in the neuroradiology division, I had no idea of the quality of individuals and their skills that I would be running into, because I had been in a very, very good hospital and lots of very, very well-trained, superb physicians. When I got to the Toronto Western Hospital, I said, wow, these people are terrific. They are smart. They are well-trained. I immediately became comfortable in that position. And so I'm going to get back to my wife later, because I think we influenced both of our careers. And if it wasn't for her, I don't think either of us would have achieved what we were able to do. We were supportive. It's kind of like having dinner and saying, okay, I'm a neuroradiologist. I've been consulting with you for these years, but I have these other neurologists and they're asking me these questions, and vice versa. So my wife's more famous than me, by far. She's the mother of pediatric stroke. That's how her career at the Hospital for Sick Children evolved. And what she did was she raised awareness of pediatric stroke. Many times a young child, say 5 years old, would have trouble moving an arm, and no one in the emergency room, no one would recognize the fact that they were having a stroke. So she raised the awareness of this condition, which is really important because you do not want to miss this problem in children. And so she created an international stroke registry. And within that registry, she could see who were getting strokes, what was the background under which that led to the stroke, how were those children treated. So one of the great anecdotes I have about how this evolved was that we both were invited to give presentations at the World Federation of Interventional Neuroradiology and Therapeutic Neuroradiology. And this is in Budapest. And most of the people doing interventional imaging or neurointerventional work, they put catheters into people and they try to take clots out. They had been doing this in years for adults and it proved to be effective. There was no evidence that this worked in kids, and yet they were doing it. And they were publishing papers on this. And they had no randomized controlled studies to prove what they were doing was effective. And the clotting systems in kids are very different than adults. They're immature. So medical treatment is even uncertain in these children. In fact, she developed such expertise that she was on call not for the city, for kids with stroke, not for the province, not for the country. She was on call for North America. We would get calls at 2 o'clock in the morning from cities in the United States with children who came into emergency rooms with strokes, and she was advising physicians what to do because she had the information. So we played off each other. I helped. Oh, and then when we were at this meeting in Budapest, she was one of like 3 women in the audience. She was the speaker. She got up there and told most of the men that you need to stop what you're doing. And there was a hush over the audience. I thought they were going to, I don't know. I felt like I'd have to go up there and, protect her and run her off the stage. In fact, they gave her a standing ovation when she finished her presentation. So that's the impact she had. And she followed the same principles. She wanted to so she was less of a technological innovator. She was a clinical innovator. And we both played our careers off each other. And that's why we were so successful. We had each other to do that. So the next step in the evolution of my career was meeting with Carl Terbrug, who was a division chief, and he's internationally famous. He is a neurointerventionalist. He's a scholar. He's an innovator. He's a great teacher. But one of his greatest assets was in building teams. And when I came to the Toronto Western Hospital, he had a team that he built of neuroradiologists that were excellent. We all worked extremely well together, and we moved the needle in neuroimaging because of that, both clinically and in research.
Good to know that the shortcomings of the American immigration system was Canada's gain, because for all of you who are listening, as you can see, someone who was in the US, who was in MGH, who considered that the pinnacle, he moved to Canada. He moved to Canada not with the idea of staying back here. He just moved here for a couple of years and always planned on going back. But then met the people here, met the system here, met the culture here, met the compassion which we find here. And as David rightly pointed out, Canada loves creating teams where people thrive off of each other. And as you can see, that he has been extremely successful and thrived as the father of fMRI in Canada. So I just want you to listen to our previous episode in which we had Dr. Anya Keeler, next president of the Canadian Association of Radiologists, where she highlights pretty much the same thing as to how people who come to Canada fall in love with it and never want to leave. So Dr. Mikulis, where do we go from here? So you were inspired by CT, worked with MRI, pushed the boundaries of functional MRI. But let's say someone's starting early in their career and they're looking for something to push. What do you think is going to be the next biggest advance in radiology?
Well, it's interesting you asked that question because we have been, one of the biggest advances in radiology occurred when MRI was developed. MRI continues to evolve. It becomes more and more sophisticated, sensitive to detecting pathology and to actually looking at the functional aspects of how the brain is working. And I think what's going to happen is that we may move to even higher field strengths. So currently, the field strength in an MRI system allows us to get the signal of the brain, and it's directly related to the strength of that magnetic field. So the field strengths, as they increase our sensitivity to actually image the brain. So let me give you an example that I think is going to be very interesting. The work that's being done currently with research MR systems is at a 3 Tesla field strength. We now have clinically approved 7 Tesla MRI systems. And we have in place, through Slate Foundation at the Toronto Western Hospital, an MRI physicist, Camille Uladag, who is now working at that field strength. Although the magnet doesn't yet exist at the Toronto Western Hospital, he is collaborating with South Korean scientists. And what he's doing with the 7 Tesla MRI system, he is looking at the highest level of imaging ever performed in human beings, living human beings, of the gray matter of the brain, the cerebral cortex. This is where much of the interaction and signaling that's going on that produces every quality that the human brain elaborates. How we think, our cognition, how we sense things, how we feel pain. So what he can do with that MR system is, at very high resolution, look at the different layers of the cerebral cortex. There are 6 layers of the cerebral cortex, and they're all interacting with each other. That's going to be the future of functional imaging. He is going to see how that networking is evolving during tasks. So for a patient, for example, if a patient or a volunteer is given a task, try to remember what you did yesterday for me while I'm doing the imaging. Or there's a complex problem that you're dealing with either at work or at home. Think of that problem while we're doing this imaging. And we're going to be able to dissect how the brain is interacting at a much higher spatial resolution, at a finer detail than we've ever gotten before. And I think that's going to provide a wealth of information on not only how the normal brain works, but how it's altered in diseases. And some of the diseases that we cannot currently diagnose just by imaging MRI alone. So let me give you an example of that. If I put somebody with schizophrenia, a 20-year-old who just developed schizophrenia in the MRI scanner, and a 20-year-old who's completely healthy, I cannot see any differences in their brains. But I believe that these techniques that he's developing will be directly translatable. Again, an example of translational research having clinical impact in being able to say, okay, maybe you felt that maybe your brain's not working just the way you've expected it to work or have been experiencing how it's working. Something you feel is wrong. What if we do a scan in that person? Can we try to detect a disease that's developing before it has major clinical manifestations? And I think that's one of the major areas where functional neuroimaging is going to take us in the future. Now, everybody talks about artificial intelligence, and I think the artificial intelligence component is only going to aid both the clinical ability to make these determinations, but it's also going to play a role in understanding and disentangling how the brain actually works.
So the piece where you mentioned that higher field strengths and advanced functional imaging might help us identify some of the diseases which we did not have an organic or a structural abnormality that we could detect, might have huge ramifications in the field of mental health. Because mental health issues are considered a crisis, and the government is spending a lot of money on trying to improve that. The problem with mental health has always been that the only way to diagnose it is to get information from the patient, but mental health is affected. So the quality of the information, it's difficult to make reasonable inferences out of that. But now having another objective counterpart to be able to see what's literally going on inside their brain might help give better therapies or better solutions for this subset of population. And that's something really, really exciting. And if that solves the problem of mental health in the next 20, 30, 50 years, that would be a huge, huge achievement. And it's great that you've helped move the needle on that aspect. And Dr. Mikulis, I need to come back to my original question, the legendary gunslinger. We have looked back at the path you have come, such an incredible and amazing path. We now know what your legacy is. But where are you going? Are you hanging up your boots? Is this the beginning of another new adventure? What are you looking forward to after your retirement?
I'm looking forward to a couple of things. First of all, I haven't stopped doing my research. So I think one of the most important translational innovations I've made was developing what we have called the brain stress test. And for those people who obviously would not be familiar with it because this is not fully disseminated yet, the brain stress test is completely analogous to the cardiac stress test. So the cardiac stress test that the cardiologists use, what they do is they stimulate blood flow through the arteries, the coronary arteries that supply blood to the heart itself. And in those patients who have chest pain or have symptoms that they may have a problem with the blood vessels going to the heart, they stress the heart to produce flow in those vessels. And if there are blockages in those vessels, they can determine with the cardiac stress test how significant those blockages are, and they can decide their management as a result of that information. I've done the same thing with the brain. In fact, last August, we just got Health Canada approval for a device that we invented and patented called the Respiract. This is a device that patients breathe on while they're getting their imaging done in the MRI scanner, and the imaging we do is sensitive to blood flow. So if they have a narrowing of a blood vessel in the brain or in the neck, we can determine what the impact that narrowing has on delivering appropriate amounts of blood to the brain. Because like I mentioned before from the fMRI, if a network in your brain turns on, so if I'm tapping my fingers, there's a very specific network that we can see on the images that turn on. When I say turn on, they start signaling. But because neurons are very energy demanding, that signaling process is very demanding of energy. They have to have literally a surge of blood flow going through that network. So if I tap my fingers like this, in that network, there's a surge of blood flow. What happens if there's a narrowing of the artery that's going to that area of the brain? Well, two things can happen. One, it doesn't have much of an effect at all. But if it does, we need to detect it and we need to deal with it. This is where we have developed, through this brain stress test, what I believe is the most effective way to determine whether or not the blood flow can be sufficient when axons and neurons become active. No one else really is able to do this to the same extent because we have a quantitative way to deliver a stimulus that makes blood vessels to open up, and that's what the device does. So my goal in the next several years is to continue to push the research on this device and to get it into the clinic. And we've succeeded now. Our first success in the United States has been at the Mayo Clinic. We think they see the value in this, and I think this will become more disseminated. Right now, the way we assess this is with resting blood flow measures, and I believe that they're not adequate. They can tell the presence of circulations, but not the effectiveness of the circulations that are feeding the important parts of the brain that could potentially be compromised. And my second role is to start taking care of myself from non-medical issues, because now I've had this whole burden of on-call and after-hours work. That's gone now, so guess what I'm taking up? Photography. How could that be better? It's right in my field. I used to do it when I was an undergraduate, and I'm planning to do that in a very aggressive manner during my retirement.
Well, the standard answer to the question as to what are you going to do after retirement usually stems something around, oh, I want to travel more. Oh, I want to sit in my boat and do fishing. Oh, I want to go to restaurants and eat. But your answer was very different. You wanted to continue to push your research. So you know what they say, right? You can take a person out of radiology, but you can't take radiology out of a person. And even your hobby was photography or taking images, which is what you've been doing throughout your entire career. So, that's a sign of a career well-lived, living out your passion. So, Dr. Mikulis, at the end here, looking back at your career, would you have done something differently? What advice would you like to give to people starting their careers, people in their mid-careers, or people thinking of taking up radiology as a specialty? I know you've given us a lot of advice that it's okay once in a while to be the bad boy of radiology, breaking a few rules here and there, moonlighting when your chief says no, or, just being a nerd, staying in the hospital all day because you can still meet your to-be wife there in the hospital, or it's okay to break rules and, send a page to the girl you're interested in, asking her out for a date. But beyond these, what other advice can you give the listeners?
My advice is always ask questions, always be inquisitive, always acquire more knowledge. It doesn't necessarily mean you have to be a researcher. Even in academic medicine, I think it's important to stay up with the current literature. Try to be discerning about what you're reading. There's a lot out there, and we're overwhelmed with information. And I think it's even more critical now in young people in their careers to become very discerning when it comes to, should I take this information and change what I'm doing? I think that's a huge challenge. For researchers, I think never stop asking questions. It's the same thing. Be aggressive. Try to be innovative. Try to take what you have available and take it to the next level. And pay attention to your mentors. I subliminally paid attention to some of my mentors, but then I took some of the advice from my mentors and put it into practice. And more often than not, they were correct. And I think that's the major advice: is always be inquisitive, always listen to advice, and always listen to the mentors who have played important roles in your life.
In the words of the famous English poet, who's called the father of poetry, Geoffrey Chaucer, all good things must come to an end. So must this podcast episode, and so must the incredible career of David Mikulis. Dr. Mikulis, you have been an inspiration to all of us when we were here. We looked at his life story as to what inspired him, what kept him going, and what continues to drive him. And he ended up aptly saying that people should just keep asking questions. Keep asking questions, stay curious, and that would keep the passion kindled inside you always. The fire of trying to find something new, trying to push the boundaries is always going to burn bright. Ladies and gentlemen, that was Dr. Mikulis, Professor, Director of JDMI Functional Neuroimaging Lab at UHN and University of Toronto, who just retired yesterday. You were listening to Radiologists, a podcast by University Medical Imaging Toronto, the largest medical imaging group in Canada. Produced by Ina Levchuk. Learn more about us at universitymedicalimagingtoronto.ca and follow us on social media at Imaging Toronto. Thank you, everybody. See you in the next one.